any unilateral process. Okay, next time. Next, what we can detect by inspection, it is type of respiration. Type of respiration may be thoracic, may be abdominal, may be mixed. How to understand what what type of respiration? Usually, we carefully observe uh, like what muscles take part in respiration, or what movements we can see. There's only chest movements, abdominal movements like this. And I think you heard the respiratory, thoracic type of respiration more typical for women, abdominal type of respiration more typical for men. And so sometimes vice versa, when we have ladies, if they have some respiratory pathology, can use like abdominal muscles for breathing, like this. Uh, After that, about respiratory rate, what you should know, how to count it. Usually we imitate palpation of the arterial pulse to don't show patient anything, because who knows, can breathe faster like this. So you will place your hand, like palpation of the pulse, you will place your hand and the patient's hand on the chest wall, and you will count for 1 minute. Like inspiration, expiration, that is one time. And you can meet different information, but in American textbooks is written what 12 to 20 is normal for respiratory movements, like breathing movements, a minute. In Russian textbooks you can meet 16 to 20, it is during the day, and 12 to 14 during the night. In average, 12 to 20, that we can consider. And so usually about tachypnea, so you will by objective examination, by inspection, you will assess not only respiratory rate. Respiratory rate we have is normal, that what I showed, it may be tachypnea, maybe bradypnea. Tachypnea it is more than that 20, brady is less than 12, like this. And also will assess respiratory depth and respiratory rhythm. Depth of respiration, it is again carefully you will observe like movements. So how maybe it will be superficial, or maybe vice versa, some like deep respiration like this. And after that, we have some disorders of respiratory rhythm, disorders of the rhythm of respiration. I think you studied it before when it was when you were first year students. Once you studied, I think. So these types of respiration, pathological types, accompanied by disorders of rhythm, I think it is just of rhythm of respiration. What kind do we know? It is Groca, Chain-Stokes, Usmaurus, and Biota respiration. This slide you can see like two different. It is Groca respiration and Chain-Stokes respiration. So it is different in depth. You can see, look, Groca respiration, it is little bit better so it's Russian language when the Chain-Stokes respiration. So if to compare, what are the main characteristics? We can see different in depth. At first, it is like superficial respiration becomes deeper, deeper, deeper. After that, again, more superficial like this, and after that it will be like waves, The increase depth, decrease depth of respiration, like this. In early stages of conditions, same with chain stocks, because if it is acute or chronic insufficiency, some cerebral circulation and brain hypoxia, sometimes hypoxia, but in initial stage you can have growth respiration. After that, it will be chain stocks, like it is like stage. So, but in chain stocks respiration, what you can see, I saw in my experience. So at first, superficial respiration becomes deeper, deeper, deeper. After that, turn to superficial, and after that, we have period of apnea. Apnea, it is absence of breathing. This period can last around, I think, 1 minute. When I saw my patient, I thought patient died because absence of breathing. And after that, we have again appearance of superficial respiration, and becomes deeper, deeper like this. So change of respiration is pathological type of respiration as a group respiration tool. Biot respiration, you can see here like spirogram. Biot, usually it is deep, regular, I'm about the deep and same in depth respirations. Here written like hyperpnea, so it is deep respiration, and which alternates the period of apnea. We have same in depth, or deep respiration, so it is like patient breathes. After that, we have period of apnea. We don't see any breathing movements. So this period usually, this period usually shorter in comparison with change stocks respiration, but same in depth. But after that, period of apnea, absence of breathing. Examples: meningitis, agony. That you can see. Kussmaulus respiration. Kussmaulus respiration. It is so typical for hyperglycemic coma. I think maybe you remember about this. What are the main characteristics of Kussmaulus breathing? Kussmaulus respiration is deep, noisy, and rare. So it is deep, it is rare, and in additional noisy respiration. Sorry. So I think it is enough information about pathological types of respirations. After that, to measure circumference of the chest, we usually use centimeter tape. We are necessary to apply centimeter tape if it is anterior surface level of the fourth rib. If it is posterior surface, it is level of angle scapula. Angle scapula corresponds level of 7 rib. So anterior 4th rib, posterior 7th rib. You will measure this during the quiet breathing. After that, ask patient like maximum inspiration and maximum expiration, and you will like check difference, and like you can see here the normal, if this difference more than 5 centimeters, abnormal less than 2 centimeters. It was chest circumference. After that, palpation. I think I will not tell about medium palpation. I will tell about essence, like main, I think, basic information about this. So palpation. What are the main like types of palpation? Types of palpation. What you can see on this slide. Not every type can be used for respiratory system. Now, we have superficial palpation, yes, we will use it. About deep palpation, it is usually for some abdominal organs. And about ballotment palpation, if we have some fluid, as a rule in abdominal cavity, when liver ballotment palpation, kidney ballotment palpation we can use. And we also have bimanual palpation, when the both hands like take part in palpation. Just only types. Just like general information about palpation. And what are the main goals of chest palpation, of respiratory system palpation? We can meet like difference. What epigastric angle palpation? It is palpation, but it is like a refinement of the data obtained during the inspection, because we usually assess form of the chest. If you remember, form of the chest, it is inspection, but without epigastric angle detection, we cannot. So we usually do it. And for example, equalitative expansion of the chest. Do you remember? We also place our fingers like this. So it is to know something addition about date of inspection. After that, superficial palpation. By superficial palpation of the chest, what can be usually the anterior surface, posterior surface, ribs, intercostal spaces, palpation. You can detect the diffuse or local like pain or tenderness in the chest. Sometimes by palpation can be detected pleural effusion rub. It may be so rough, you will consider it next lecture, because it is auscultatory phenomenon, this pathological breathing sound like this. And subcutaneous emphysema, you have already studied this, so like play piano, subcutaneous emphysema, and some masses on the chest wall that you can feel by superficial palpation. After that, can be detected position of trachea, elasticity of the chest or rigidity if you wish, and vocal fremitus. Now, at first, here written about elasticity of the chest wall. About elasticity, what is the method of detection? Usually, like you can see down these pictures, you will place your hands vertically on the chest, like just sternum region, and opposite on the spinal cord. And by compressive movement, by spring movements, you will squeeze it, if you wish, in anterior-posterior direction, at first, but don't place your hand in level of the epigastric region to remove stomach contents, and from lateral directions. Who has when the chest can lose elasticity in case of the fluid air accumulation in pleural cavity, when we have pleural adhesions or some tumor of the pleura. It may be not only, it may be chest wall that changes the classification of the costal cartilages, or to do emphysema of lung because it is hyperemesis lung tissue that is very difficult to compress. No, in case of musculoskeletal changes, like you can see, like pathological form of the chest, pathological forms. Next is vocal fremitus. Vocal fremitus, what is this? What is the phenomenon? It is the conduction of the sounds of the tracheal bronchial tree to the chest wall, what can be detected by palpation, by your fingers, like this. And what is the method of the vocal fremitus determination? You will place your fingers, you will place your hands on the symmetrical points of the chest, and patient will, I said, that is transmission of the voice, transmission of the sounds, like the tracheal bronchial tree to the chest surface. So patient will pronounce some sounds. If in English it is 99, 99. If you wish to use Russian language, 33. The sounds which can cause maximum vibration. And after that, you will apply hands on symmetrical points of the chest. When you will do it, you can say after pronunciation of some words, certain words, you will feel vibration. So symmetrical. So it may be different. So where you will place your hands, anterior surface of the chest, it will be above clavicle, it will be below clavicle. But usually, no, for me, I don't like position of this because we prefer horizontal position like this, because here it's hard, better to place horizontally below clavicle. After that, we have lateral part of the chest to place your hands where you should ask patient to raise hands and put on the occipital region, like this. So, and you will place your hands. Patient will pronounce again. Next. You will check on the posterior surface. Posterior surface, like you will place your hands in 4 points. It is it is suprascapular region. After that, between scapula, but to palpate between scapula, you should ask patient to cross the hands and place on the shoulder. Because like this, you can the patient can displace like scapula and to wide the surface wear. So suprascapular region, twice between scapula, you place your hands, and after the patient will assume usual position and he will place your hands below ulnar shoulder blade. And like this, you will analyze what did you feel. It was the same or different because it is like comparative palpation, what you felt. And you can see here changes of vocal fremitus. It may be increased, may be decreased. We have pathological and physiological changes. This slide, you can see physiological changes. Like I said, it is transmission of a sound. It depends on, it is high-pitched or low-pitched voice. So who has a low pitched voice, it is transmitted better, like this. About high pitched, you will feel little bit. Uh, uh, During this, I think, next lecture, and I think after that again, very important to know laws of physics. I think why? Because it is a transmission of sounds. When we have some degrees of transmission, it depends on thickness of the chest wall. So if if patient has acidic form of the chest, the sound will be like can be transmitted better. So you can feel like increased vocal premiums, and also just physiologically in upper part of the chest, vibration is just like more prominent, like this, in comparison with lower part of the chest in healthy persons. And I said about the low, like high-pitched voice, and plus, if we are asthenic patients, here hypersthenic, because for hypersthenic it is a little bit thicker. I'm about chest wall thickness, like this. This slide can illustrate. In future, it will help you to understand. I will try to explain little bit causes of weakening and intensification of vocal premiums, because it is palpatory method. You will place your hands down on the symmetrical points, not emerging. Oh, sorry. Here you can see illustration of the different pathology, like different syndromes, what you will be explained in future. This picture, it is healthy lung. For example, when we have weakening of the vocal premitus, look, here the fluid in the pleural cavity, do you see? So lung was compressed, lungs like lower body of the lung was moved upward because we have lung collapse, compression. If you will, sorry, I lost my mouth. So if you will place your hand over fluid, what you should remember for future, the fluid and the air conduct the sounds very bad, very bad. So if you will place your hand over fluid, it will be weakened vocal premitus, because vocal premitus can be transmitted till here. Here we don't have any like bronchial tree. Lung was compressed. Here only fluid. What transmits sounds very bad like this. So we have weakened vocal premitus. In comparison, if you will place your hand over compressed lung, but emerging, your hand will be here. Sorry. So imagine your hand you will place over compressed lung. Compressed becomes a more solid consistency. In this case, and like the stability of bronchus resolved. If to place your hand over compressed lung, the vocal premitus increased here. So different pathologies, like the same pathology, but in future you will study it is Garland triangle, it is a level of like compressed lung. So here vocal premitus increased. It is if to like compressive atelectasis, like this. After that, we have if air accumulation in pleural cavity. Fluid, according to gravity, usually accumulates in the lower part of the like pleural cavity. If it is air accumulation, we have it like around the lung, and lung compressed near the root, like this, and emerging. I am about distance, because vocal premitus transmission of sounds from from vocal cords, from the tracting bronchial tree to the chest surface. What about this distance? Lung is here, your hand is here. What about vocal premitus? What will you feel? I think in some situations it depends on the amount of air. If it is little bit, it will be weakened vocal premitus. If it is a lot of the air, you will feel nothing. You will feel nothing, like this. After that, what here illustrated obstructive atelectasis. So we have something like tumor here, lung collapse. So I said vocal premitus transmission of the sound along tracheal bronchial tree to the chest surface. how sound here may be transmitted if we have barrier, if we have obstruction of the bronchus. Due to obstruction, sound cannot be transmitted. So obstructive atelectasis, I can cause like as a tumor. It may be some foreign bodies. For example, in this case, the vocal fremitus will be decreased. And one more situation when vocal fremitus can be decreased, it is like pleural adhesion, thickening of the pleura. The emerging here inflammation, here fluid, here air, here only pleural adhesions, but it can cause thickening of the pleura. A thickening, it is again increased distance between your hand and the lung tissue. So in this case, vocal fremitus will be decreased like this. We have situations when the vocal fremitus is increased. I said before about compressive atelectasis in comparison to fluid accumulation. After that, this picture illustrates the lobar pneumonia, it is lobar consolidation of lung tissue. Consolidation, when the lung tissue becomes so solid, solid tissue conducts sounds very good. So the preserved possibility of the bronchus, and here we have solid tissue. If you will place your hand on the solid tissue, the sound will be the vocal fremitus vibration, it is will be more distinct like this, so it will be increased. Here written about focal consolidation. Here lobar consolidation, here focal consolidation, but consolidation, so solid tissue. I have already said what it will increase conduction of sound like this. Here last we have cavity. It is lung abscess, cavity in the lung tissue. The cavity, it is good resonator. So when you will place your hand over cavity, so it will be increased, much increased. Like you can compare the cavity like the speaker, so it is so much so resonator. And if you wish, here written the causes of weakening, and I think that here is weakening of the pathological weakening of the vocal fremitus. I have already explained the some moments, because thickening of the chest wall, because it depends on thickness. I explained before. You can think about this. Fluid, aerial cavity. I enumerated. I think I showed. I demonstrated it. Next, and about vocal fremitus, I explained everything by pictures. If you wish later, you can mark it, you can note it. Now, deviation of trachea. Trachea, usually in healthy persons, we can see on the middle of the neck. In some situations, it can be displaced. We have several techniques of how to detect position of trachea on the neck. So we can use one finger method. This picture can illustrate it. We can use 2 fingers methods and 3 fingers methods like this. So in future, you will be explained and you will be shown. When only very quickly I will explain when trachea can be displaced. Trachea can be displaced to healthy or affected site. To healthy site, when we have accumulation of fluid air in pleural cavity. That if we have somewhere the trachea together with organs of mediastinum will be shifted to the healthy side. But vice versa, when we have lung collapse, blood collapse due to obstruction, for example, it is obstructive atelectasis, lung fibrosis. So in this case, it will turn trachea to affected side. That is only examples what I said. Okay, next about percussion. I'm afraid I will try to explain something about percussion. No, it is a tapping. That tapping about discovery of this method. That you can see it as it was discovered by Austrian physician Leopold von Ruger in 1761 year, and we use now different types of percussion. I will not tell what is written where, but please look here. We have two different types: immediate percussion, direct and indirect percussion. The first method was discovered by this author, so it is on Ruger. What is the main you can use it. It was direct by whole I think hand, flexed palm, and you can tap like this. It is direct percussion. The Janowski method was also like direct percussion, but by one finger. If you remember ostalgia, we usually detect by percussion. It is direct, by one finger. So just Janowski method. And Obraztsov method we usually don't use because the one finger should slide from another, like this. No, it is not convenient for me. And direct percussion, according to Janowski, we can use. About Obraztsov, I don't think so. Now we use indirect percussion. Indirect when can be used two fingers. One is the pleximeter and one is a plexer, it is hammer. And earlier it was with some instruments, what you can see. Now we can use like Sokolsky method. It is theory and Sokolsky method. I will explain what is the essence. That we have also like different percussion according to walls. There is comparative percussion. There is topography percussion. Comparative percussion, it is compare sounds, what you can hear of the lung tissue, for example. It is to find some pathology. About topography percussion is used to find borders of the if lungs, it is borders of the lungs. So we have upper, lower border. By topography percussion we can detect mobility of the lower lung border like this. But usually borders of some borders and size of some organs like this. And according to strength of the percussion, it may be different. Maybe you heard superficial, light percussion, and loud percussion. Loud percussion, you will use more force to tap, and this sound can be spread deeper, so depth I think around 7-8 centimeters. So light percussion like 5-6 centimeters, and superficial or super light percussion, if you wish, it is 3-4 centimeters. The comparative percussion is loud. According to loudness is loud. Topography percussion is light percussion. Only for percussion of the heart. In future you will study this. We have relative and absolute borders of the heart. So for absolute borders of the heart can be used super light percussion. For lung, we don't use super light percussion. Only loud, that is comparative, and light, it is topographic in this case, like this. Sounds, according to loudness, I will allow me to skip it. We have something. What kind of percussion sounds you can hear after percussion, during percussion? All the lung tissue, usual lung resonance sound. And according to characteristics, it is different in duration, I think loudness, and like frequency. Better to explain if you will, if you will draw a triangle, so what it can illustrate? Tympanic sound, it is longest, it is long, and low pitched usually, because do you see like pitch? From base of the triangle, like till apex, you can see. But if you will remember, the tympanic sound has the lowest pitched and pitch, and after that, like higher. I'm about here. You can see duration. So here shorter, and shorter. We have like what types? Lung resonance sound. We have what we can hear in healthy persons. Over lung tissue only, like clear lung resonance sound. In other regions of the body, we can hear like other what? Oh, for example, of the lung tissue, it is lung resonance sound. If it is what you can see that here lines, uh, dullness sound, but dullness may be absolute dullness and relative dullness. Absolute dullness, it is like stony, dullness, no, if you will percuss over muscles like this, of bones. Uh, but we have relative. Look, for example, this picture doesn't illustrate very well that this material, but I will tell by my words. Maybe you will understand me. So we have liver. Liver usually location below the diaphragm, and some part of the liver like covered by lungs. When we usually percuss where the liver, what is covered part of the liver, what is covered by lungs, will give, I think, relative dullness. But only liver, it is airless organ, will give dullness sound like this. Tympanic sound can be heard over our intestinal region, of the stomach, the intestine, like that, because where is gas, so you can hear tympanic sound. If it is pathological conditions, it is pneumothorax, for example, or maybe tympanic sound can be heard over cavities, if it is abscess of the lung but free from the fluids, like this. So I will return. Here you can see characteristics of the sounds. Sometimes we have the Bangkok sound can be heard as specific. Like tympanic can be heard only in case of one pathology, just emphysema of lung. And in some situations, it may be combination. Dull tympanic sound, for example, due to compression of the lung, you can hear this like this. Here written about, I think, rules of percussion. But students, unfortunately, our time is up. Our time is over. I will not have time, if little bit, till the end. I understand. I can finish, but about percussion, I can explain. I think no, at least half of the hour, maybe a little bit longer. So during your lessons, you will be explained how to perform percussion. So because here